quite understand. I'm Rupert Hinds, I'm a paediatric gastroenterologist at Monash. I'm also a lecturer in paediatrics. So when you make your way to the fourth year, some of you I know have already passed that, you will see a fair bit of me, both clinically but also in a variety of teaching settings. And it's great being in a hospital because it allows you to do both of those things, a bit of research, a bit of clinical stuff, and a bit of teaching. And it makes for a good job when you can combine all those things at a high level. I don't want to talk too much about paediatric gastroenterology, but I'll just mention paediatrics briefly. I think paediatrics is a great speciality because every child at a different age has a different set of problems and different physiology, and you're constantly on your feet thinking and you're constantly on the move. They're not just little adults, they have a whole range of different disease pathologies. From babies to teenagers, there's a whole different set of things that we face. And what I like about gastroenterology, just briefly, is that we combine a bit of the esoteric thinking stuff with a bit of their stuff, a bit of hands-on stuff, you know. I get my hands dirty, I get some scrubs on, I wear gloves, but I'm not just, you know, sticking bands on people's hemorrhoids or you know, putting someone's bottom that's fallen out back with my stapler. So I think that being a physician who does some interventional stuff is, you know, has the best of both worlds, and I really enjoy doing that. Now, to give you a brief sense of where I am and how I got here, just like our moderator, I'm from the United Kingdom, and I came here for a perceived better quality of life. And there's no doubt Australia has that. You know, I'm not just saying that because I want you to be my friend. It is better over here. I clearly didn't come over here for a better standard of political debate or higher quality sport, because I should have stayed in the United Kingdom. But in all other aspects of life, I think this is a great place to be. When you finish your medical student time, you must think, God, there's about 1 million careers that I could do. If you're like me, there's a couple you think, geez, I'm not going to do them. For me, gynecology, yuck, right? ENT, sputum. So they were out for me. I could have done a whole host of other careers, to be honest. And to be honest, when you finish your undergraduate degree, it's like being at Vue de Monde, okay? You can pick the salmon, the steak, or the pork belly. They're all good decisions. You know, the other person might have a steak, and you might have a pork belly, but you're all going to go home satisfied. And that's medicine, to be honest. You can pick any number of careers, and you end up happy. And that's my standpoint. You don't have to make the right decision first time, but you might want to make it the second time, otherwise you'll be 90 by the time you're a specialist. You've got a bit of time to think about it, you really have. For me, I chose paediatrics, as many of you will, perhaps as some of our panel did, for pretty arbitrary reasons. The residents were really nice. I think there was a registrar who was really quite attractive, and that really got me interested. And the consultants were lovely. They seemed to have a focus and an interest in us that I hadn't always found in, once again, not being deliberately negative, but some of the adult surgeons. Because when I did my orthopaedics, I went to an X-ray meeting at about 4:30 in the morning, I think. They decided which hammer they were going to use and which saw. Then they said to the registrar, you go and do that, I've got private patients. And that was the end of my interaction, and I had the rest of the day off. Whereas the paediatricians on the ward, they were lovely, they were kind, they taught me, they nurtured me. They didn't leave their Porsche running, you know, while they went to their private rooms. And I think us physicians were just a bit kinder, you know. So I would make the case that being a physician offers a huge range of opportunities. So of course as a surgeon. I want to finish quickly, because I know that 5 minutes flies by, the cut or cure business, okay? There is no doubt there are some situations where you need an operation, okay? If my femur is sticking out of my leg, okay, I need a surgeon. If I've got a massive fungating tumour in my cecum, you know, I need a surgeon. I wouldn't disagree, okay? The question more personally is, can you have a satisfying career? Can you cure, diagnose and treat without wielding a big knife? And the answer is clearly yes. Let's face it, 500 years ago, surgeons weren't regarded as physicians. They were in the same territory as butchers. And that's really different now. You know, that's why they call themselves Mr., of course, because they didn't used to be allowed to be called doctors, and it's reverse snobbery. So physicians, we get to do stuff, we get to think about stuff, we don't need to chop stuff. That's the first thing to say. Also, in your lifetime, a lot of the stuff that surgeons do will become physician stuff already. Interventional radiologists, endoscopists. We do loads of stuff now that used to be surgical. And to be honest, I see a future where what's left for the general surgeons is bottoms and hernias.
The end with bottoms and hernias. My fingers were itching towards a red card at that point, a bit earlier, when there was a little bit of personal abuse coming in. We're just beginning to warm up, okay? So I've got a question for Rupert, and this is one to do with young kids. What are your top tips for getting shy or unruly children to talk to you or let you examine their bottoms and hernias?
I always make a point, and I make this point to many of you who I've taught, that you've got to treat different age kids differently, and you've got to be aware of the sensitivities of a given age. I make the point, and I've made this to many of you, that if you're a post-school age child, particularly if you're a boy, you can sort of wear your adult hat, expose them, look at them. You know, if you ask them in sensible, normal, plain English, they're going to do what you want to do. And if they're behaving badly, then it's probably part of their parenting rather than being appropriately scared. In those children who are younger than school age, you've really got to be careful. You've got to make use of their parents, their mothers, and they are the greatest resource you'll have in a clinic, because they can often persuade the kids to do stuff that they wouldn't otherwise do. I always make the point, this is probably a little bit too clinical, but you know, our ears, and once again, I'm not saying this just to be unfair to surgeons, but our ears as physicians at least are very useful. We need to listen to things. We use a stethoscope, okay? They don't always, but we do. And when you use a stethoscope for a small child, if they're crying, you can hear absolutely nothing. So it's really important, if hearing is part of the examination, to get the child cuddled, swaddled, and listen before you start undressing and poking and prodding them. And I think that's really important. The other thing, and I say this because I think, you know, us males are sometimes insensitive, is I said this probably this morning, I find it immensely insensitive when a sort of periatric girl gets exposed by a male student examining her. So I think you have some care of the sensitivities of your teenage girls, you know, when you examine them. But all in all, bigger kids, they're like adults in many ways. You can get away with doing all the stuff you would. Don't do stuff that's going to make anyone upset first. Don't poke someone in the back here, for example, if you don't have to. And furthermore, in little babies and kids, make use of their parents. They're the tips, really. And I think, to be honest, you learn it on the job. When you do it for a while, it becomes second nature. When you first start doing it, you have to think about it. But any of you who end up seeing a fair number of kids in PD, in ED, in GP, and PEDS, you'll do it easily. But when in doubt, use the mum. That's my advice.
Rupert, how do you handle the parents in paediatrics? Half the battle's dealing with the parents and not the child.
I would agree entirely. It's part of the challenge. You're dealing with both the patients and what should be the patient's advocate, but it's sometimes the exact opposite. And I think it's very difficult. I think you have to sometimes say to parents, you know, quite forcefully, that you are there to be looking after the child and try and address them directly rather than addressing the parents. I think the other thing is that some parents, you have to recognise, even as a subspecialist, are not going to be happy with your answer, and recognition that you can't make everyone happy all the time is equally important. So I think, you know, when you're a junior consultant, it's very hard to say, look, you know, you probably need a second opinion, because I don't think we have an appropriate relationship. But, you know, otherwise it's just a question of acknowledging that you can't always please the parents, and the child is the most important one in the